Good morning, and today we're starting our conference with a talk on stroke. Sarah K. Rostansky is an assistant professor of neurology at NYU Grossman School of Medicine. She is also the stroke director and associate chief of neurology at Bellevue Hospital. Her clinical focus is on the treatment of patients with acute ischemic stroke, particularly with an interest in TIA and minor stroke. After receiving her Bachelor of Science from Cornell University, Dr. Rostansky earned her MD in 2010 from NYU School of Medicine, and she completed an internship in internal medicine there at Bellevue Tisch. She then completed a 3-year residency in neurology at New York Presbyterian Columbia and 2 years of postgrad training at NYU Columbia Medical Center as the Vascular Neurology Clinical Fellow and an NIH StrokeNet Fellow, in addition to service as a New York State ECRIP Fellow. She's part of the training core at the Center for Stroke Disparities Solutions at the NYU School of Population in Health from 2015 to 2016. She's a native New Yorker, and she has a particular interest in local stroke systems of care. She was co-chair of the New York State Interfacility Transfer Work Group and served in the leadership of the Northeast Cerebrovascular Consortium from 2020 through 2022. In 2018, Dr. Rostansky received the Innovator Award for Teaching Excellence from the NYU Grossman School of Medicine. And in 2023, she received the Innovator Award from the NYU School of Medicine for her pivotal role in the transformation of the stroke and neurocritical care services at Bellevue Hospital. She was also the 2024 Bellevue Hospital Doctor of the Year. Dr. Rostansky is a board certified in neurology and vascular neurology, and she's a member of the AHA and the American Academy of Neurology. So thank you very much for joining us, and we look forward to a great talk.
Thank you so much for having me. I'll be covering a lot of information today, and I hope that there are questions. The more interactive, the better. So at the end, we'll certainly have some time for questions, and these slides will all be available for you as well. There's a lot to get through. I have no disclosures that are really relevant to this talk. So overall today, I'd like to give you an overview of stroke and TIA epidemiology, and then spend some time focusing on TIA risk stratification, review evidence-based treatment for management of ischemic stroke and TIA, and then I'll touch on secondary stroke prevention, really from a lens of sort of what is the evidence. So just to start us off with stroke and TIA epidemiology, stroke is the 5th leading cause of death in the US. It used to be the 4th leading cause of death. That change happened probably about 5 to 7 years ago, really a result of improvement in blood pressure as to why stroke is becoming less deadly. However, stroke is still very, very common. There are nearly 800,000 strokes a year. Vast majority are first-time events. When you think about stroke, sort of 3 main subtypes: ischemic stroke, hemorrhagic stroke as in intracerebral hemorrhage, and hemorrhagic stroke as in subarachnoid hemorrhage. The vast, vast majority of strokes are ischemic strokes. 87%, 10% are intracerebral hemorrhages, and 3% are subarachnoid hemorrhages. There are well-described race to ethnic differences in the incidence of stroke. And stroke is sort of the most common cause of hospitalization for a neurologic disease. This is some data from NHANES. The last time it was updated was really 2020, but looking at the prevalence of stroke by age and sex, and what you can see is that stroke is really a disease of the old. We certainly see young patients with stroke, but as people get older, their risk for stroke dramatically increases. The lifetime risk of stroke is higher in women than men, and that's because women live longer than men. Each year, about 55,000 more women than men have a stroke, and again, that is really because of the differences in lifespan between men and women. And stroke patients over the age of 85 make up about 17% of all strokes. So when we look at the U.S. population, just in terms of some race ethnicity breakdown, and this data is updated as of 2022, you can see that there are race ethnic differences in terms of stroke deaths. sort of what jumps out at me is that Black males have by far the highest age-adjusted death rate for stroke, whereas non-Hispanic Asians females have the lowest stroke rate. So these are sort of well-validated race ethnic differences in multiple populations, but important to be after. So when you think about TIA, that's what we're going to focus on now. So TIA is a transient focal neurologic deficit that's felt to be due to ischemia. And really, the definition of TIA is a clinical one. So it implies that there's no evidence of infarct on the MRI. Infarct on MRI is generally assessed with a DWI sequence, and you can see tiny little areas that suggest ischemia. There used to be a definition of TIA that was really time-based. So any transient neurologic symptoms under 24 hours, that would be a TIA. That changed in 2009, where there's now more of a tissue-based definition. So TIA is transient neurologic symptoms felt to be due to ischemia, lack of blood flow, whereas a minor stroke can be transient neurologic symptoms due to ischemia, but really with no infarct on MRI means it's a TIA. If there's infarct on MRI, it means it's a minor stroke. Sort of a minor point, but TIA is not a time-based definition. TIAs are quite common. It's difficult to get estimates because, as I mentioned, because the definition means there's no evidence of acute infarct on imaging, it's really a clinical diagnosis. So, and there's no ground truth in sort of how do you verify that someone has a TIA. It's all based on kind of clinical assessment, risk factor evaluation. So the actual number of TIAs every year is difficult to pinpoint, estimated between 250 and 350,000 a year. Short-term risk of stroke is high after TIA and minor stroke, and that's why we really care about these. 1 in 15 over the age of 65 has reported a TIA, and these are a really common cause of hospitalization in the US, as you can see here. So how do we approach TIA risk stratification? As I mentioned, the reason we really care about TIA, or transient neurologic symptoms felt to be due to ischemia, we care about TIA because it's a very a high risk condition for certain patients, and high risk really for subsequent stroke. So looking at this data, this is old data looking at emergency department patients who are followed for 90 days after a TIA diagnosis. And what these authors found was that at 90 days, 25% had had a stroke or other adverse event. I'll point out here that 2.6% had a cardiovascular event and 2.6% actually died. This is after a TIA, so transient neurologic symptoms. When we look at the stroke event rates at 90 days, 10.5% of the population of these TIA patients had stroke at 90 days. However, over half of that risk happened in the first 48 hours. So that's really the population that we're interested in figuring out. Someone who presents with transient neurologic symptoms felt to be a TIA. How do we know that this is a high-risk person who's going to go on to have a stroke? And what can we do to prevent that stroke, most importantly? What is the outcome we need to do, and how do we make that risk assessment? So TIA risk prediction, the best score we have, and this is very widely used, is called the ABCD2 score. And it was really derived from that data I just showed you from that ED population, and then verified in 2 different large epidemiologic cohorts. But it's a score that goes from 0 to 7, and it predicts the 2-day risk of stroke. There are multiple features that go into this score. So age over 60, you can get 1 point. Blood pressure, and that's the initial presenting blood pressure over 140 over 90, 1 point. And the clinical symptoms, is there focal weakness? That gives you 2 points. Is there just a speech deficit with no weakness? That gives you 1 point. Any other symptoms, you get 0 points. And then the duration of the TIA, over 60 minutes, you get 2 points. 10 to 59 minutes, you get 1 point. Under 10 minutes, 0 points. And then diabetes, yes, 1 point, no 0 points. And so your ABCD2 score can range from 0 to 7, and the 2-day risk of stroke based on the ABCD2 score varies widely. You can see here this graph on the right shows varying levels of stroke recurrence after a TIA broken down by time point and by ABCD2 score. So the purple bar is at 2 days, then next is 7 days, 30 days, 90 days. What we really care about is that short-term risk of stroke. And as the ABCD2 score increases, the short-term risk of stroke increases. ABCD2 score, for example, a score of 2 or 3 has a 1.3% 2-day risk of stroke, whereas an ABCD2 score of 6 or 7 has an 8% 2-day risk of stroke. So there are certainly limitations to the ABCD2 score, and probably the biggest limitation is that it does not accurately discriminate the presence of symptomatic carotid stenosis or narrowing in the carotid artery, which is sort of an important high-risk condition to talk about that will affect the risk of subsequent stroke. ABCD2 score also does not reliably discriminate between the presence or absence of AFib. So ABCD2 score of 4 or higher is generally considered a high-risk TIA, but again, it's only one tool to help risk stratify. It is not it's not a diagnostic tool, number one, and it has limitations. Okay, so acute TIA management. Just go back one second. Yeah, sorry, I realized I did skip a slide. So just to focus a little bit more on TIA, on stroke after TIA. So this is data that came from a large TIA clinic in France. And what I'd like to draw your attention to is the graph on the right side. And this breaks down the risk of stroke after TIA based on the cause of the stroke. And so what you can see here is that there is a gray line that really clearly separates out from the other lines with the highest early risk of stroke recurrence after a TIA. And this was TIA due to large artery atherosclerosis. Large artery atherosclerosis refers to either symptomatic stenosis in the arteries in the brain or the arteries in the neck, like carotid stenosis. And that is the highest risk condition that underlies TIA that has the highest risk of recurrent stroke. So that's really where our TIA workup has to focus, is how do we figure out which TIAs are due to symptomatic large artery atherosclerosis, because that has the highest risk of stroke recurrence and has sort of treatable interventions. And then my next slide, which I had skipped to earlier, shows that the ABCD2 score alone is not sufficient to discriminate the presence or absence of carotid stenosis. Okay, so we understand that the cause of the TIA is important for figuring out which TIAs are high risk. Now, what do we do when someone has an acute TIA? And I'll be going over evidence-based according to the American Heart Association. So again, class 1, level of evidence A, sort of the strongest recommendation with the best data. And obviously class 3 is do not do, risk is greater than benefit. So TIA evaluation. So the workup is really guided at figuring out why did the TIA happen. Again, thinking about those curves that I just showed you, large artery atherosclerosis, narrowing in the arteries in the neck, narrowing in the arteries in the head, has the highest risk of stroke recurrence. Workup should happen as soon as possible and should be ASAP, but really should be initiated within 48 hours of symptom onset. And if someone, has transient neurologic symptoms that go away, they should definitely go to the emergency room. Patients should be counseled on that. One of the most important parts of the workup is vessel imaging, and that's vessel imaging to identify whether or not there's symptomatic stenosis in the carotid arteries or the intracranial arteries. And the reason to do this is that if someone has a TIA due to symptomatic carotid stenosis, early revascularization, meaning whether that's surgery with carotid endarterectomy or revascularization with a carotid stent, has the best chance of reducing the long-term risk of stroke. For patients who have TIA due to narrowing in the intracranial arteries, there's sort of best medical management that can be instituted acutely to help decrease the risk of subsequent stroke. Part of the TIA evaluation that's also essential is an MRI of the brain in patients who can tolerate that, who don't have contraindications. And the reason for the MRI of the brain is to understand, is there the presence of acute infarct? The reason acute infarct matters is that may confer an even higher risk of recurrence in the short term. And then for patients where you suspect a cardioembolic source, EKG, transthoracic echo, and long-term cardiac monitoring is also an important part of the TIA evaluation. And one of the questions I frequently get is sort of, well, what if a patient tells me about a TIA, a couple days later, should I send them to the ED? And I really think the time from symptom onset plus the risk assessment, and risk assessment being ABCD2 score plus any known carotid disease, for example, can help determine whether or not someone needs to be referred to the ED immediately or for an expedited outpatient workup. In general, a TIA or stroke within the preceding 7 days plus one of the following was sort of felt to be high risk in a study from Australia and should prompt ED referral, and that's an ABCD2 score 4 or higher. That's really how we think about high risk. Anyone having crescendo TIAs, which are 2 or more events in a short-term period, that's very suggestive of symptomatic stenosis. Patients with AFib, patients who are on anticoagulation therapy, reason being you can't actually tell if transient neurologic symptoms are due to ischemia or hemorrhage without a CAT scan, and any known carotid disease. And so if high risk, they should be referred to the ED. Again, acutely if a patient realize the symptoms, they should always present to the ED. Now, again, practice context also matters. So if you're seeing a patient maybe a week later and you're able to complete an outpatient workup in an expedited manner, then that's reasonable at that point. But really up to 7 days, if they have any high risk features, they should go to the emergency room. And then in some places there is access to TIA clinics and rapid specialist referral, although TIA clinics are sort of much more common in Europe than they are in the US, unfortunately. What's the evidence-based treatment for TIA treatment? So acute dual antiplatelet therapy for high-risk TIA is an evidence-based intervention. High-risk TIA is defined as ABCD2 score, again, a 4 or higher. And really acute dual antiplatelet therapy, which refers to a load generally of clopidogrel plus a load of aspirin, and then continued for short term, generally 21 days, has a significant effect on reducing early short-term stroke risk in high-risk TIA and minor stroke patients. Minor stroke defined as an NIH stroke scale of 3 or less. And this is really based on 3 large trials, the CHANCE trial, POINT trial, and Thales trial, which showed that acute dual antiplatelet therapy for a time-limited period can reduce that early risk of stroke after TIA. For patients with low-risk TIA, single antiplatelet is fine, and for patients who have AFib, for example, they should not be treated with dual antiplatelet therapy. They should be treated with anticoagulation. And this is just showing sort of meta-analysis of patient-level data from 2 of the 3 trials I referenced, showing the difference in early stroke recurrence between the dual antiplatelet therapy group and the single antiplatelet therapy group. And what you can see on the y-axis is the probability of recurrent stroke, and on the x-axis is the days after randomization. These were patients who were all sort of treated acutely. These 2 curves in terms of probability of recurrent stroke really separate very, very early, suggesting that the effect of dual antiplatelet therapy is an early one. So it's really something that is really time sensitive and should be started within 24 hours for the best risk reduction. The greatest benefit is with 21 days of treatment. And then after 21 days, moving to single antiplatelet therapy. It's not a long-term intervention. And then for carotid revascularization, so there's a high early risk of recurrent stroke in the setting of symptomatic carotid stenosis. The benefit is for CEA was shown to be 26% risk of recurrent stroke without CEA versus 9% risk of recurrent stroke with CEA. And that's for stroke at 2 years. That gives a number needed to treat of 6. Now, one thing to remember is that this is old data. We really don't have new trials on symptomatic carotid stenosis because it's sort of pretty much taken as fact that these patients should be revascularized. However, medical treatment has gotten better from the 90s when these studies were done, generally before the widespread use of statins. But identifying symptomatic carotid stenosis is important because carotid endarterectomy really can, or carotid stenting, I should say, really can reduce that early risk of stroke. Earlier treatment is better, so you have a 1% chance per day of recurrent stroke in the first 2 weeks after a TIA or minor stroke due to a symptomatic carotid stenosis. And with moderate stenosis, which is 50 to 69% stenosis, that benefit of revascularization is still there, but it's not as profound. So really, it's those patients who have a TIA are found to have carotid stenosis over 70%. The carotid stenosis is felt to cause the TIA. That is the patient that needs rapid revascularization of their carotid to prevent recurrent stroke. And that revascularization can happen with CEA or carotid stenting. So just to summarize, TIA prognosis is guided by the underlying mechanism, really focusing on large artery disease, carotid stenosis, or intracranial athero as the highest risk mechanism in terms of early stroke recurrence. ABCD2 score can approximate the short-term risk of stroke. Early workup is key to identify both. Is there a high risk vessel stenosis? Can benefit from revascularization, and is there an infarct on MRI, which also may confer a higher risk of early stroke recurrence. And then the acute use of dual antiplatelet therapy for a time-limited duration of 21 days can reduce the early risk of stroke in high-risk TIA and minor stroke patients. Okay, now we'll touch on acute management of ischemic stroke. This is sort of what we do in the hospital and why patients need to come to the hospital so quickly. Don't need to belabor this point, but time is brain in the setting of an acute stroke where there's a blockage in an artery, whether it's a small artery or a large artery. Revascularization, meaning restoring blood flow, is the most important thing to minimize the loss of neurons. And really every minute matters in terms of the number of neurons that are lost. There are two ways that we revascularize vessels, either with medication, so that's IV thrombolysis, whether that's alteplase or tenecteplase, and that's for all ischemic strokes. It doesn't matter the level of the vessel occlusion. And then mechanical thrombectomy, actually going into the artery, pulling out the clot, and that's really for large vessel occlusions and some medium vessel occlusions. So when we think about thrombolysis, TPA was the initial thrombolytic that was used up until very recently. It's still in use in many places. It has a number needed to treat of 8 for excellent functional outcome. And it was initially approved for up to 3 hours from last known normal. That means the time the patient was last known to be well, which has really been extended to 4.5 hours from last known normal. But it's a really time-limited treatment window. The downside of TPA and tenecteplase is that there is a risk of hemorrhage. Now, the risk of benefit is larger than the risk of hemorrhage, but there is a significant intracranial hemorrhage rate of about 6%, 3%, 1 to 3% fatal, with a number needed to harm of 33, number needed to treat of 8. So the benefit certainly does outweigh the risk, but there is risk of hemorrhage. That risk of hemorrhage really goes up with the more severe the stroke. So in minor strokes that are functionally disabling, for patients in the window for treatment, IV thrombolysis is indicated. And then the effect of TPA is really, or thrombolysis in general, is really time dependent, meaning the sooner the treatment, the better. And really, treatment is given up to 4.5 hours from last known well. And that's from additional data from 2008, where the time window was expanded. The number needed to treat is 14 at 4.5 hours, where it's 8 at 3 hours. So again, the benefit of TPA is sooner rather than later. Biggest problem we have with IV thrombolytics is that patients just don't present to the hospital in time. So this is old data. This data hasn't been updated in many years, but it's not meaningfully different. Sort of when we look at secular trends at single centers, the vast majority of patients do not present to the hospital within the treatment window for IV TPA. So what you can see here is the overall proportion of patients who were treated with TPA, and then these are the number who sort of arrived within 2 hours of this overall population. But in general, majority of patients don't present in the window to get treated. It's a small treatment window. It's a very strong guideline indication. Within 3 hours of symptom onset is, regardless of patient age, is a class 1 level of evidence A. And then in terms of in the 3 to 4.5 hour window, the guidelines have a little bit of a distinction based on age. That is not something we use in clinical practice because of other trial data that really did not support considering a patient's age when thinking about the window for thrombolysis. So it's a class 2A level of evidence B that in the 3 to 4.5 hour window, IV TPA can be as effective in older patients as in younger patients. And again, in my clinical practice, both at Bellevue and NYU, we never consider a patient's age really when thinking about the treatment window for a thrombolytic. And then tenecteplase, just to touch on this briefly, it's a more fibrin-specific agent than alteplase. It's given as a single bolus, and really it's sort of become the more common thrombolytic. And that's specifically because number one, number two, it does have better efficacy in breaking up large clots. And number three, there was a study, the ACT trial, which really confirmed the non-inferiority of tenecteplase to alteplase or TPA in a general stroke population. It was also recently FDA approved for ischemic stroke earlier this year. And then when we think about sort of shifting our treatment from IV thrombolytics to large vessel occlusions, how do we suspect someone has a large vessel occlusion? Well, it's really sort of the patients who are presenting with major stroke symptoms. So hemiparesis, weakness on one side of the body, plus any signs of cortical dysfunction, whether that's trouble with language, aphasia, hemispatial neglect, not paying attention to one side, field cut, can't see in one visual field, gaze preference, all these kind of higher level cortical function plus hemiparesis is most suggestive of a large vessel occlusion. We care about large vessel occlusions because they are the most deadly types of strokes. So the presence of a large vessel occlusion alone increases the risk of the stroke being highly morbid and mortal. About 45% of acute strokes at urban academic medical centers are large vessel occlusions, and TPA or TNK, now tenecteplase, really do not work well enough. That really do not work well enough at revascularizing carotid large vessel occlusions. So what do we do instead of thrombolysis? And it's not really instead of, it's in addition to. What we do is mechanical thrombectomy. Mechanical thrombectomy is going into the artery, pulling out the blood clot, and this is probably the most exciting intervention in acute stroke in the last 10 years because of the profound effect of decreasing disability post-stroke. What I'm showing you here is a meta-analysis of 5 trials that looked at mechanical thrombectomy, removing the clot for large vessel occlusions for patients presenting up to 6 hours. And what you can see, the details are not that important. This is a stroke. This is a scale called the modified Rankin, from a modified Rankin of 0 to 6. 6 means you're dead. 5 means you're bedridden. 0, 1, and 2 means you're independent. The proportion that were independent with mechanical thrombectomy compared to the proportion that were not independent was dramatically significant. Really with a number needed to treat of 5 for independence. So this is a profound treatment in acute stroke. Essential that patients have stroke recognized and come to the hospital as quickly as possible. Mechanical thrombectomy has been shown to be effective regardless of age, and there's a lot of data in elderly patients showing that while we know that age is one of the strongest risk factors for a poor outcome after stroke, still patients with large vessel occlusions who are elderly benefit from mechanical thrombectomy. Mechanical thrombectomy within 6 hours of symptom onset is a class 1 level of evidence A recommendation. And then depending on their baseline level of functioning, mechanical thrombectomy is still indicated. And then when we think about that data was really up to 6 hours. About 5 years ago, there was an expansion of the data looking at how do we figure out which patients can actually benefit from this treatment, mechanical thrombectomy, in longer time windows. And this came from the Diffuse 3 and Dawn trial, which really tried to specially select the patients who are presenting beyond 6 hours with a large vessel occlusion, who had evidence of brain at risk on advanced imaging called CT perfusion. And what these studies showed was that in patients who get CT perfusion, which is sort of an advanced imaging technique that's done at comprehensive stroke centers, the patients who are presenting with large vessel occlusions up to 24 hours who have findings of salvageable brain Mechanical thrombectomy in that population has a number needed to treat of 3 for functional independence. So these are patients who could go from, bedridden without treatment to some even leave the hospital. So it's all about figuring out who these patients are who have a blockage in a main artery and is their brain to save, bringing them to the centers where they can be treated. And it's a treatment that really has the ability to be life-changing. So from an AHA guideline standpoint, again, there's really no reason to withhold treatment up to 24 hours in patients who have a large vessel occlusion. And that's really the time window we think about. 24 hours with favorable brain imaging, there's benefit for treatment with mechanical thrombectomy. And then the newest area sort of where treatment has been expanded is even in patients who have established infarct or large areas of the brain that already have an obvious stroke. If they present within 24 hours, there's actually still benefit for mechanical thrombectomy in a large number of these patients as well. So it's really a treatment that has changed stroke care for sort of the most severe types of strokes, the large vessel occlusions. Okay, and then the last portion of the talk, we're really going to focus on secondary ischemic stroke prevention and then touch on hemorrhage as well. So as I mentioned earlier, ischemic stroke makes up about 87% of strokes. There are different subtypes: large artery atherosclerotic, small vessel disease or lacunar infarct, cardioembolic, and then cryptogenic, meaning we don't actually know the cause of the stroke despite a thorough workup. Figuring out why a stroke happened is the most important sort of focus of our stroke workup because the underlying cause of the stroke determines both what treatments we use and what the risk of recurrence is. And this is just a breakdown. I don't need to belabor it, sort of breaking down the different types of stroke and based on overall sort of likelihood. One thing to mention is that cryptogenic stroke is sort of the category we're left with after a thorough workup. And there are really 2 main types of cryptogenic stroke: what we call ESIS or embolic strokes of unknown source versus non-ESIS. So when we think about cryptogenic strokes, it kind of depends on whether we think the stroke was due to an embolism versus not. And that's an assessment we make based on looking at the pattern of stroke, what the MRI looks like, what the echocardiogram looks like. There are a lot of factors that go into that assessment. The goal of a stroke hospitalization is really to figure out the stroke etiology, initiate secondary prevention, and then provide supportive care. There's good data that patients who are treated in dedicated stroke centers have better outcomes. They're less likely to develop aspiration pneumonia. They're less likely to develop DVTs, more likely to get evidence-based treatment. And then the typical stroke evaluation, it's really somewhat similar to TIA evaluation that we talked about. Brain imaging, whether that's with CT or MRI. MRI is definitely indicated in some cases. Some cases, MRI may not be as useful, especially when we don't know the etiology. MRI is very helpful. We definitely need vascular imaging to understand, is there stenosis in the carotid arteries, in the vertebral arteries, in the intracranial arteries. Vessel imaging can be done with CTA, MRA, or carotid and transcranial Doppler. Cardiac evaluation depends on the patient, but TTE or TEE, cardiac monitoring, and then basic lab work with lipids and A1C, and then more sort of specific testing in very rare conditions where we'll do a conventional angiogram, look for inflammatory testing, but that's sort of a small proportion of stroke patients. Stroke and TIA risk factors sort of very similar to cardiac disease. I won't go over this in detail. And then secondary prevention recommendations, really we'll touch on various aspects of this. So antiplatelets. From an antiplatelet standpoint, there's data for an acute antiplatelet treatment in ischemic stroke for patients who did not receive TPA, and that's really old data called the CASS trial. Aspirin is the standard choice for all patients in the acute stroke setting who are, number 1, not eligible for IV TPA, or number 2, not getting treated with dual antiplatelet therapy for TIA and minor stroke. And then anticoagulation, what's the risk of, what do we use acute anticoagulation for ischemic stroke? And the answer to that is really no. Anticoagulation used to be kind of the standard of care for, and when I'm talking about anticoagulation, I mean in the acute setting. And there were 2 negative trials that showed starting anticoagulation right away actually has a higher risk of bleeding without a risk of reducing ischemic stroke. So what that really comes down to is that aspirin is sort of the first treatment you give in the hospital, and then for patients who have AFib, anticoagulation will be started after the acute stroke period, whether that's 2 days later, 3 days later, depends on the size of the strokes. So from an AHA guideline standpoint, aspirin is recommended in all patients with ischemic stroke within 24 to 48 hours. If you receive a thrombolytic, you don't get aspirin right away. In a subset of patients who have minor stroke, like we discussed, rather than aspirin, it should really be dual antiplatelet therapy with a Plavix load for 21 days, and that treatment should be given as quickly as possible. And then urgent anticoagulation is not recommended for patients with acute stroke. For non-cardioembolic stroke and TIA long-term, antiplatelet is recommended rather than anticoagulation for long-term stroke prevention. And then for patients who have non-cardioembolic ischemic stroke, really aspirin versus Agrinox versus Plavix monotherapy, they're all the same. Either one is sufficient for secondary stroke prevention. Hypertension, there's acute treatment of hypertension where we actually want the blood pressure to be high in the acute stroke setting and then lower it over 48 hours. That's really to maintain blood flow to the brain in the setting of a blockage, for example. And then really antihypertensive therapy is generally started during the hospitalization, but over time is sort of when we like to get to our long-term goal, which is under 130 over 80 for secondary stroke prevention. And blood pressure long term is really the most important modifiable risk factor for ischemic stroke. Differences in blood pressure control account for about half of the excess risk of strokes in Black patients compared to white patients. You can see that systolic blood pressure reduction of 10 millimeters of mercury can lead to an average 41% risk of 41% reduction in stroke risk, and eliminating effective blood pressure control could eliminate 35 to 40% of all strokes. And so really the optimal blood pressure target is under 130 over 80. And there really is not strong evidence to suggest one agent over another. There's been studies in various different agents. Really, it's about compliance. And then so statins, how do we manage cholesterol? One of the most important things to think about from a cholesterol standpoint is what's the cause of the stroke? Is it a stroke that's mediated by atherosclerosis or is it not? So there's data that long-term, and this was not an acute trial, but long-term patients who have an ischemic stroke, who have an LDL over 100, regardless of what the cause of their stroke is, have a lower risk of stroke recurrence on atorvastatin 80 versus placebo. And so that's really standard intervention if the LDL is over 100. Now, for patients who have an atherosclerosis-mediated stroke, whether that's carotid stenosis or intracranial stenosis, really the lower the LDL is better. So 100 is a much, much too high level to sort of be thinking about statin therapy. And we really want to drive that LDL even lower than 70, as low as possible. So it kind of depends, and the AHA guidelines mention this, that there's a different goal based on the subtype of stroke. And so really for patients who do not have an athero-mediated stroke, if their LDL is over 100, they should be on atorvastatin 80. And if they have atherosclerotic-mediated stroke, LDL should be under 70, but really should be as low as possible. For AFib, I'm sure you guys are all familiar with AFib. Prevalence increases with age, and among the very elderly, AFib is the single most important cause of stroke. Really, there's no data at all to withhold anticoagulation in patients with atrial fibrillation. The CHA2DS2-VASc score is used in stroke neurology. The only caveat is that the vast majority of patients we see with AFib have already had a stroke, so they almost all have an indication for anticoagulation, and that just becomes a little bit tricky in patients who have also had an intracerebral hemorrhage. From a treatment perspective, really the guidelines don't favor one of the newer anticoagulants over another. I will say in the stroke world, we almost exclusively use Eliquis or apixaban because of the perceived lower rate of bleeding. Thinking about the Averroes trial, where apixaban versus aspirin in patients with AFib who had a high risk of bleeding had the same risk of bleeding. So we always use Eliquis for the most part in stroke, but really the guidelines are agnostic. But there's no reason, even despite a patient being elderly, to consider withholding atrial anticoagulation for AFib. And the one thing I'll mention is that falls are frequently cited, but there's been studies done that like patients really would have to fall, 10,000 times or something crazy to justify withholding anticoagulation in a patient with AFib. And then carotid revascularization, which we already had talked about, is an indication for symptomatic disease. Earlier, the better. And I think this is the last trial. Yep. So this is all stuff I covered. We can basically stop here. Intracerebral hemorrhage is just one slide on controlling blood pressure as the most important intervention. I think that's it. So if there are any questions, I'm happy to answer them at this point.
Okay. Thank you for a really great and comprehensive talk. I appreciate it. It's such an important topic for those of us who are geriatricians and palliative care physicians, because it has such a high risk in older adults. One of the questions that our attendees asked was in terms of secondary prevention in a stroke that perhaps wasn't initially symptomatic, but was found on workup for dementia, for example. What are the recommendations for secondary prevention for those kinds of incidentally found strokes?
Yeah, that's a great question. So it really kind of depends on what the pattern is on the MRI. There's a little bit of a difference between finding small vessel disease or a chronic lacunar infarct versus a sort of chronic embolic appearing infarct. So in the realm where I think probably the most common thing that's encountered is small vessel or microvascular ischemic disease, chronic lacunar infarcts, those it's an interesting area because it's not clear whether or not aspirin is indicated. And there's actually a nice position piece recently sort of arguing both sides of it. My personal practice is that if a patient doesn't have a high risk of bleeding, on the MRI, another sequence to kind of be sensitive to is sequences looking for microbleeds, especially in elderly patients. So if a patient doesn't have significant microbleeds, has an indication for aspirin from a cardiovascular standpoint, although unlikely if they're not on it at that point. I sometimes will start them on aspirin after a discussion, but in many patients I don't because there's not a clear evidence base. Now, if a patient has evidence of sort of a territorial stroke or an old embolic appearing stroke, that's a case where I will start aspirin and actually probably do somewhat of a workup look at their blood vessels and get an echocardiogram. So that it's really a difference between the microvascular kind of chronic lacunar infarct versus the more concerning chronic embolic appearing infarct. And sometimes that's not easily distinguished on an MRI read for a non-stroke neurologist. I will acknowledge that point.
Okay. Thank you. So complicated question, it sounds like.
Yeah, there's not sort of I wish that there was like an easy algorithmic approach to it, but there isn't.
Okay. Thank you. Thank you for that thoughtful answer. Another question from one of our viewers: what emerging risk factors do you think are under-recognized in cryptogenic stroke, and how do we integrate them into secondary prevention strategies?
I think probably one thing that I'm not sure we'll be able to integrate, but I do think that there's a decent chance, and we've already seen some early data on this, that like there's definitely a possibility that COVID at some point and multiple COVID infections do increase stroke risk. And we see a lot of stroke in the young, and many patients sort of have really cryptogenic strokes where we don't find a cause. And I do wonder what, especially in some younger patients, whether COVID, in ways that we really don't understand and can't exactly quantify, is kind of a potential long-term stroke risk factor. There are other things to think about, and I mentioned this especially in elderly people. So there's a really strong association from sort of from an observation standpoint on infection preceding stroke. And so in an elderly patient, even someone who just, has a UTI, that can be a stroke trigger. So sort of thinking about recent infections, it's well demonstrated in flu as well, preceding infections as stroke triggers in elderly people. And frequently these strokes are cryptogenic strokes, and the thought is maybe there was some atrial fibrillation that's kind of the inflammatory milieu of the infection triggered. Again, these are not necessarily well developed causal pathways, but there is clear kind of observational evidence of this association, and something probably to kind of think about more frequently in risk assessment of these patients with cryptogenic stroke. Other thing I would add is that occult malignancy is another concern for in patients with cryptogenic stroke, especially as they get older.
Okay. Thank you so much. Fascinating.